We have Seeing the Cough, which is chest x-rays today with Dr. Saini. Now, my name is Sydney Cruikshank, and I'm from the PHN education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself, that is Darkinjin country, and I'd also like to pay respect to elders past, present, and emerging. Now, I had the pleasure of having a beautiful connection test with Komal yesterday. And it was just a really amazing conversation. I just felt like so wholesome after it, just in regards to career, motherhood, health, and lifestyle. And it was really beautiful. And I just wanted to, I guess, just ask a couple questions to just introduce yourself and get to know you a little bit better. So
Yeah,
let's
sure.
start with mainly your background in radiology and how you transitioned from that to general practice.
Yeah, sure. So, when I finished med school when I was in 2013, so it's been a while now, and then I got onto radiology pretty quickly. It was sort of more, the mentors that I had at the time were all radiology, the terms I got as an intern resident, and then I did that and did the accredited training for 3 years and sat a lot of exams, and then really found myself missing that people interaction and talking to people. And I think what really got me is the fact that there was no like ongoing follow up, or you just report a scan and you'd make all this little, actually not little decisions, quite big decisions that would impact the patient, but you'd never get to find out what actually happens or see the patient or really have a personal experience with them. I could never see myself doing something where it was just one specialty. So that's why I did radiology. And then I'd always thought general practice in the back of my head was another area where you're just looking at undifferentiated problems and then, synthesizing things, and they're actually very similar in how you think each time, because it's both are very fast paced and both are undifferentiated, and both you need to know really breadth of things about. So what I missed in radiology, I felt maybe I'll get it back in general practice. So I quit radiology training and then had to transition back, sitting some exams to get back into GP. And I've really had no regrets in my transition because I really, yeah, I think I really kind of lost what being a doctor was about for me anyway, doing radiology. And that's been rejuvenated through general practice. And I'm really passionate about um, the preventative side of things and how we can sort of help people, really, yeah, I absolutely love it. And I have no regrets in being in the position that I am now. So I'm a few months away from finishing training. So I'm just doing my extended skills right now. Done all my exams. Yay, happy days. That was a crazy time having to do it with a newborn. But yeah, it's all over and done. And I'm really looking forward to being a fellow of the college eventually. And how I landed in medical education. Well, I've always had sort of an interest in, educating people. And also for me, anyway, on a selfish sort of note, I find teaching others a great way to consolidate my own knowledge as well. And I've done that all throughout my career in various roles. And so I thought, when I saw this job come up, I thought, wow, what a great time to just, expand my skills and learn from other people who've been doing this for a long time. And so, yeah, I've just been doing the Registrar of Medical Education role for ROCGP sort of since the start of this term, which is since Feb. And I've really enjoyed it. I've had some little great mentors that are teaching me like lots of different skills and learning presentation styles. And it's just it's been a great way to consolidate lots of things that have been floating around in my mind. And I've really enjoyed that. And that's where I'm at right now.
Yeah, amazing. Well, thanks, Chris, for the recommendation. We're very lucky to have you. Touching on, but right before you get into it, one more thing in terms of preventative measures that maybe that you take that you want to see incorporated more into general practice. Do you want to elaborate a little bit on that?
Yeah, well, I was like we were talking about yesterday, Sydney. I'm finding that I'm, giving patients like weight loss, diet, exercise, all of that kind of stuff. I'm really passionate about. So, um, I myself, I'm a firm believer you can't do things and tell people things with great conviction unless you practice what you preach. So, I myself, engage in triathlons and I do a lot of personal training myself, and I try to live a very healthy lifestyle. So when I'm actually saying this lifestyle modification to people, I feel like for me it's been tried and tested. And then I can actually, some of the challenges that I face, I can tell them, hey, look, in my day-to-day life, I struggle with this, and this when I'm trying to do this, or juggle this with my daughter when I've had no sleep. So because I'm seeing it, actually, I'm attracting a whole bunch of patients who are more younger mums as well. And so I really connect with them on that level. And I feel being able to not only give guideline-based advice, but actually practical advice through my own, day-to-day experiences is what has really helped me connect with people and for them to take me seriously as well. And I found that really beneficial. So I hope that answers your question. I'm not really sure if it did,
No,
but
no, it does. It does. I think it's just beautiful. But yeah, no, we're looking forward to today. We'll see how we go. You might have to minimize all of our little
yeah.
screen there just so we can see your presentation, and then we'll get into it.
Okay. See you. I will minimize you guys. And
Perfect.
oh, there you go. I can still see you, Sydney. So there's someone
All right.
there. All right,
Not for
guys.
long.
So
Not for long.
no, that's okay. So today, what I'm going to today's session, the way I'd like to run it is I will be asking the audience some questions, and I'd like you guys to get involved. And this is a real safe space, so please have a go at some of the clinical cases that we'll do later on. The way that I've structured this talk is to give you guys some basic sort of review of how to read chest X-rays, and then go ahead and really practice what we've learned. So without further ado, let's get cracking. So seeing the cough, that's my talk title. Some of the learning objectives are as here. So we're going to learn a bit about the basic anatomy, a systematic approach to reading chest radiographs, how to actually appropriately request them, and interacting with your local radiologists, and some common findings that we can see that can represent some serious disease. So we'll start off with a clinical case first. I might have to minimize this further. Hang on. There you go. So Belinda is a 53-year-old female who presents with a 4-week history of worsening dry cough. This is associated with right-sided tenderness on her chest, worse on inspiration. She's an ex-smoker and she's currently on HRT. So what are the key features that you see from this presentation? And please feel free to turn on your video, have a go. Yeah. Anyone?
I want to start with the ex-smoker status.
Yep, that's great. Anything else?
Obviously, it's a 53-year-old female, and she's got this sort of subacute history of worsening dry cough.
Yes, that's very important. So subacute presentation, ex-smoker. And I guess the next thing for me anyway that stands out is it's pleuritic in nature because it's worse on inspiration, and she's also on HRT. So pretty much most of that case has been designed to be important. So that's good. Any differential diagnoses that come to mind based on these key features that we've just discussed?
And could I ask, when it says tenderness, because I read that, I was thinking, is this like, is it pain to palpation, or is it a pain, like a pleuritic pain type thing?
Yeah. Yep. Okay. I see how that could be ambiguous a little. I think it's pain with worse on inspiration. So
okay.
It's meant to be more pleuritic in nature.
Okay. Cool.
Yep. Any differential diagnoses anyone can think of?
Well, PE for me, pulmonary embolus, but then I would really like to know whether she's just recently started on HRT, or has she been on it for 12 months, 18 months? And then I would like to know, has she recently traveled?
Yes.
Sitting still for any length of time?
Yes, no, absolutely. Very good questions. PE is also my top differentials, and yes, you would need to ask all those history questions, so that's excellent. Anything else anyone can think of? What are some of the diagnoses not to miss? So PE is one of them, and what are some of the other things that one would think of?
Chris has added in pneumonia.
Yep. How do I see the chat? Is there a way to see it at the same time? Not really. I'll leave it.
I think it's tricky when you're presenting. Yeah.
Yeah, okay. No worries.
Gordon suggested lung cancer, given the smoking history.
Yep. No, that's great. Yep.
What about a viral pleurisy?
Yes, definitely. It's on the list as well. I think pretty much those are the major things. So PE, infection, pleurisy, and lung cancer are the major differentials. When you look at MERTAG, some of the things that they say not to miss would be atypical chest pain, so like an MI of some sort. But with a subacute onset, that's less likely. So I think you guys have hit the nail on the head. What else would you want to know? Someone's already asked. Sorry, I don't know what your names are because I can't see you. But basically, what else would you want to know? So things like, travel history, how quickly the HRT is initiated, all that is very important. Is there anything else you would like to ask in particular to help you differentiate some of those differential diagnoses?
Any shortness of breath, any weight loss?
Yep, excellent. That's pretty much it. So length of smoking history, family history, unintentional weight loss, and constitutional symptoms to suggest malignancy would be also very important to filter through. So on examination, her general appearance, there's no increased work of breathing. Her vital signs are all within normal limits. Her BMI is 19. Her heart sounds are dual and there's no added sounds. She's got a reduced air entry in the right lung apex, and otherwise it's a normal exam in terms of auscultation. So what are the initial investigations you may want to order in this context?
I think I would order a chest X-ray.
Woohoo! Correct answer. And that's my segue into my talk. So thank you for that. You're excellent, whoever that was. So definitely chest X-rays. So when we write imaging forms, what, from your experience, like, when you're rushed, do you write in forms to get good answers, or what have you all experienced so far in your clinical practice?
Yeah, I think in terms of what to write, putting in a lot in the information section. So why am I ordering the test? What am I looking at? So if I just write chest X-ray of no additional information, the radiologist doesn't really know what I'm looking for. Whereas if I say decreased entry at the right apex, then they're going to have a good look at that area to see what's happening up there. But what I do find sometimes is I write a whole lot of information, it doesn't translate onto, when you get the imaging report back and it just is blank,
Yes.
or it says no
Yes.
information provided, and you think, oh, actually I did.
Yeah.
Yeah, but it's obviously at the transcription stage, it hasn't gone across or something. But
Yeah.
but yeah, I think, what are you looking for? Why are you doing the test, and being specific about what the test is.
Yes, absolutely. So in radiology, when I was working as a radiology registrar, your answer is only as good as your question. And that was very pertinent. So you make a really good point, Chris. Basically, if we are just writing chest X-ray, query cough, no one has any idea of the differential diagnoses. So that's why I started off with key features, DDs, and that's sort of how you should think. And that's sort of what you should translate on your imaging forms as much as possible, because it allows the other person. So, when we say, for example, when Chris said he read the word tenderness versus pleuritic chest pain, it changes a lot of differentials in your mind. And when you're seeing chest X-rays, the problem with chest X-rays in particular is when you're interpreting them, you put even 5 radiologists together, everyone sees something a little different, because it's not a 3-dimensional scan, but we're trying to get information from a projection, and there's so many variable factors. So the more clinical information you have, the more accurate your diagnosis through a chest X-ray can be. And the more you know about the history, just like in any other aspect of clinical medicine, it allows you to filter through and recognize, patterns that present in certain ways in the image as well. So definitely, it's very important to write, a good request form to get a good answer. Otherwise, and a specific another example is, say you've palpated someone's ankle and there's tenderness over the lateral malleus, it's really important to write that so they look carefully in that area. Otherwise, if you just look at thousands of ankles in like private practice, which is mostly where we're going to be referring to, then your brain just sees, after a while, you just start not seeing things unless you're rejuvenated by a question, and then your mind goes more focused in that area. Although every radiologist technically should follow a system each time, it still makes their life a lot easier, and makes your life a lot easier if you specifically ask a question and give as much clinical information as possible. So that's just aside from my experience. So that brings us on to the next part, which is approach to chest X-ray interpretation. So first and foremost, when we're looking at chest X-rays, we need to confirm the patient details. So you need to check that it's the right film, so the name, date of birth, gender, and make sure that you're looking at the right date and time. And it's very, very important when you're looking at chest X-rays yourself, if you can get access to some previous imaging for comparison, just like we do with ECGs. Chest X-rays are the same because, like I said, it's a projection of three-dimensional structures in a 2D form, so it's really hard to, it's very variable in its interpretation. Even very experienced people will see something different in a chest X-ray, so it's really important to look at something in the past and compare as sort of the interval change, which really assists in diagnosis. So a really great mnemonic that we use in radiology is called RIPE, and that's to assess the image quality of a chest X-ray. And now RIPE is rotation, inspiration, projection, and exposure. Okay, so first and foremost, when you look at a chest radiograph, you need to have a understanding of whether it's rotated, because that will then show certain structures and make things look more prominent. For example, if you imagine your chest is rotated to the side or one side, then the highlight on one side may look more prominent, and that could still be within normal limits based on the rotation. So you've got to keep that in mind. So normal chest X-ray should just have the medial aspect of each of the clavicles should be equal distance on both sides, okay, from your spinous processes, which are here. So see, this is your spinous process right here. Can you guys see my pointer?
Yep, all good.
Yes.
Yeah.
Yeah.
Okay. So here's the spinous process, and so both the medial aspects of these clavicles are equidistant. They are not. If you see rotation, then you'll see a gap in between them. Okay, so that's fine. Then inspiration, you should see the 5 to 6 anterior ribs. I know that it is hard to see anterior ribs sometimes to an untrained eye, but basically that is the gold standard. Otherwise, the other thing you can look at is the lateral rib edges should be seen. So you should see all of these rather than it being rotated. So if we're looking at the anterior ribs, this is the first rib, that's the second anterior rib. The reason why they're more faint is because this is a PA projection, and also there's a lot more cartilaginous sort of part to it. So that's first rib, second rib, third rib, fourth rib, and fifth rib just. We see that, and sixth rib is just there. So if you can see that, you're doing pretty well. Some people can also look at posterior ribs, and you should see about 8 to 10 of them. So let's have a little count of the posterior ones. Yeah, I think that's 1, 2, 3, 4, 5, 6, 7, 8. So yeah, you're seeing roughly 8. So that's a good amount of inspiration. Okay, obviously in conditions like COPD, emphysema, airways disease, you would see hyperinflation. So you'll see the 10th and 11th ribs as well. Posterior ribs, that is. Then it's really important to check the projection, because that helps you understand the cardiomediastinal ratio as well. So whether it's AP, PA, and if it's lateral, you normally won't have it labeled and you just assume it's PA. So basically, if there's no label, you assume it's PA. If it's AP, technically they should label it. Okay. Which one of you understand the difference between AP and PA chest radiographs? Does anyone know why the cardiac silhouette is larger in one versus the other?
No.
Okay. No worries.
Is it a bit to do with because the heart's closer on the to the rays being projected, it creates a larger shadow?
Yes, correct. Yes, absolutely. So in a PA, you are, now I just need to get this right in my head. Sorry, I apologize for this, but in a PA, basically your chest is against the plate and the light is coming through. And so the receptor to the actual image to the structure is closer, and so it's a smaller shadow, whereas in AP you are facing the other way, so the receptor is further away and the light source, but the structure is closer to the light source, so it diverges the X-ray and makes a larger heart. Okay, it's really not that important, but that's what it is. Okay, the next part is exposure. So really important to check the exposure. So the left hemidiaphragm, which is here, should be seen behind the cardiac silhouette. So if you can't see that, you don't have enough exposure. And also behind this cardiac silhouette, you should be able to see the vertebrae in an adequate exposed film. So those are some ways to assess image quality. The next thing is having a systemic approach. So once you've assessed the image quality and you know you've got a good X-ray to work with, then you go ahead and try to sort of understand the abnormality. And the way we do that is the inside-out approach. So you always start in the middle and then you go outwards and you look at all those things. So you do airway, breathing, cardiac, diaphragm, and everything else. And then you try to identify the abnormality. Then you look at the pattern of the abnormality, and then you come up with differential diagnoses. So just like in clinical medicine, when we look at a patient, we try to assess their history. So this inside-out approach is kind of looking at the history of the chest X-ray, and then you try and work out the abnormality, and then you look at the pattern. So you're synthesizing it in your mind, and then you're coming up with DDs. So that's why key features and clinical history will only add one more layer to help reach the common goal, which is the differential diagnosis and the diagnosis in your patient. So here we have airway. So when you're looking at the airway, you're actually, I'm going to slowly talk through this. If anyone has any questions, please do stop me. I don't mind stopping and telling you or answering your question, okay? I can't see the chat box, so you might just have to unmute yourself to speak to me. So airway, you're just looking at the trachea, then you're looking at the carina and the bronchi, and then you're looking at the hilar structures. So that's your midline. So airway, then breathing, you're actually looking at the lungs themselves and also the pleura. So the pleura actually goes all the way around. So you're looking down here, around there. The commonest way, to look at pathology in the pleura is if you think about an asbestosis chest X-ray where there's giant pleural plaques all throughout. So that sort of gives you an understanding of where the pleura will sit. Then you do C, which is the cardiac, so heart size and the borders of the cardiac, so the costophrenic angle, the mediastinal border. Then you look at, that's the cardiophrenic angle, I apologize. And then you're looking at the diaphragm to include the assessment of the diaphragm itself, because why is that important? Because fluid pulls up in this costophrenic angle. So blunting of that can mean fluid, blood, pus, etc. And also looking at this contour, if it's abnormal, whether you've got like a diaphragmatic nerve palsy, so like basically a nerve palsy, or you've got free air under the diaphragm. And then everything else will include mediastinal contours, making sure they're all in line, and that the aortic knuckle is not protruding out like in aortic dissection. And then you're looking at soft tissue and obviously the bones. So the bones are really important, but we will get there in a second and we'll have a practice of exactly how to do it. So before we do that, I'm just going to go through really quickly some anatomy, because I think if we have that in our minds, we'll be able to interpret these a little bit better. So this is our trachea, and around T3, T4 is where our carina begins, and so that's where it starts to bifurcate. And this is obviously our right side and our left side. And then you've got the paratracheal stripe. Why that is important is if you miss this stripe, it means you have a deep neck space infection of some sort, or something that's causing abnormal shifting. So you need to have a look at that. So there are lots of other conditions which is sort of out of the scope of this talk, but yeah, that's an important line to look at. Then you've got the aortic knob, and then you've got the pulmonary trunk. You've got the left atrial appendage, and this is your left ventricle. So the way that the heart is rotated during embryology means that we don't really see much of the right ventricle, because that's kind of sitting a little anterior. And so you just mostly see the left ventricle. Then this side is the right atrium, because the right ventricle somewhere around here. Okay, so this is your right atrium. And then this is the azygos esophageal reflex, recess, sorry, and then the para-aortic line. I think, you know, if you just remember this contour here, which is your aorta, if you're seeing that and that's not there, or that's blowing out into something, then you know that it's a dissection of some sort, or an aneurysm that's happening in the thoracic aorta. These are your interlobular arteries. So, you know, one of the most trickiest parts in a chest x-ray I find is actually interpreting the hilum, because how do you know whether the hilum is prominent or not? Well, that's very difficult because you have to report thousands of x-rays to really get good at that. And it's always contentious. So lots of radiologists, one may say, no, this has been the normal limits. So if you're ever struggling to figure out whether the hilar is within normal limits or not, you're not the only one, so you don't need to stress. But basically, if you see, what you need to look for is really giant, big blobs of white, which are either lymph nodes or lots of little numerous little dots of white, which are calcified lymph nodes, like in TB, sarcoid, and rip-roaring, you know, collections of free air, fluid. All of that means there's some sort of mediastinal discrepancy, and so that's what you need to look up for in our context. In terms of the bones themselves, so you know, as I said to you, in a good exposed film, you should see all the spinous processes. So this is the first, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th vertebrae. And then this adjacent to them are actually your posterior ribs, as we discussed earlier. This here is your clavicle. And then these ones here, these really faint things that you're seeing, we have to be creative in radiology. Can you see that as I'm following them down? These are anterior ribs. Now you will get these slides, so you can look at this, you know, very closely, just to get your eye in tracing all these ribs. Okay, and so here is your posterior ribs, as I said here. So the easiest way to find them is to find the spinous process and then follow them along that way. Then you know you're following the posterior ribs. And if you are trying to follow the anterior rib, the easiest way is to find the first rib, which is always going to be at an angle downwards because of the thoracic inlet, and it's the most flattest and you know, abnormal shaped rib, I suppose, normal within development, but it's to allow all the vessels and the airway and everything to come through and make a greater space in the thoracic inlet. So the best way to identify anterior ribs is to find this first flat looking rib that's almost slanting downwards, and then just follow along thereafter. Okay, so then you just go that way. Now, when I was doing radiology and I was interpreting lots of chest x-rays, a common thing that people miss is actually, and I learned this the hard way, was I had a chest x-ray of a young patient who had metastatic breast cancer, and I was reporting it, and then my consultant said, "Hey, Komal, what have you missed on this one?" And I just wasn't sure what I missed, because I went through all my system and checked everything in the chest. But really, there was this big metastatic pathological fracture of her scapula, and she had a metastatic deposit in her scapula. So it's really, really important when you're doing plain films. The mediastinum is important, all the mediastinal structures are important, the diaphragm is important, but the bones and the soft tissue on the sides are very, very important as well. So sometimes, you know, after that, I never ever forgot to check all these peripheral soft tissue areas. So I was really glad that I made a small mistake that allowed me to learn to never do that again. So I always check these areas, because you can see surgical emphysema, you can see hematoma, you can see, you know, lymph nodes, lots of things in the soft tissue, as well as the actual bones on either side as well. So yeah, that's your scapula, that's your glenohumeral joint. This is just part of it, probably the acromion process over here. Then, and we've already discussed all these, so left ventricle, a parodic line, then your costophrenic angle. Here is your left hemidiaphragm, and in your left hemidiaphragm you have a normal gastric bubble, which is obviously the air in your solid viscus of your stomach, and this side is the right hemidiaphragm. And we always have to note that the right hemidiaphragm, you know, normally should be slightly higher than the left because of the size of the liver. And sometimes if it's very, very high, then we worry about a phrenic nerve palsy. So just at this, and this is obviously your liver shadow. So if you see anything cystic looking in there, we should obviously examine it on ultrasound. Does anyone have any questions about this view at this minute? No?
No, all good.
Okay, excellent. Thank you. Thanks. So then the lateral view is also quite important. In the lateral view, you've got to use the same principle. So we're still using our spinous processes as our landmark to help us, as well as our diaphragms. So here, this is our spinous processes in this projection now. So a really good thing to look for in the lateral view is any abnormality in the actual alignment of the spine, as well as the spinous like vertebral body heights, which you should be able to see here too. So if you're seeing any crush fractures, but this view is really nice to identify something like that. Again, we have to look at all the soft tissue at the back. So if we just quickly go through the anatomy here, we've got our right humerus and our left humerus, and then here is your heart shadow here. This is your right diaphragm. This is your left hemidiaphragm, and that's your gastric bubble over there. The specific anatomy of the heart is kind of a little challenging in this view. So you're less looking at pathology in the mediastinal structures in this view. You're more looking for confirmation whether what the abnormality you see here in the mediastinum is truly a thing. So here, like I spoke to you about, is the aortic knob and then the pulmonary artery. If you see this widening out here and blowing out like in dissection or an aneurysm, then you look here and say, oh, is this contour really blowing up here too? If it is, excellent, you've diagnosed it. And the only other thing you can see that you can't see on this view in the lateral view is the anterior mediastinal structures. So if you have a giant thymus or a giant retrosternal goiter, then you should be able to see those things here as well as maybe retrosternal lymphadenopathy and maybe some pleural plaques. So that's what you're using this view. In radiology, you're always looking at something in two views, in two planes. So here you're looking at things this way, and then you're confirming them on this picture. It's often, unless something is very rip-roaring, it's often really hard to pick it unless you're very experienced firsthand in this view. So for our purposes, I'd just like you to remember the important parts are the costophrenic angles, because you can see the blunting and confirm the blunting. You can see both diaphragms, so you can check for free air. You can see the alignment of the vertebrae. You can also look at the lateral aspect of all your ribs, which are helpful in trauma cases to look for fractures. You can again see some of the lung shadows, but the mediastinal structures, you're just looking for something massive and rip-roaring, okay? And here, you always must look at the soft tissues just to make sure. Sometimes, if you have got a splenic rupture, you might see some free air here too. So that's really important to keep that in mind. Does anyone have any questions about this view at this moment in time?
No, all good.
Cool. So just with everything, like everything in medicine, we always need to have a fail-safe plan when we're thinking about presentations and trying to diagnose things. And a common pitfall in radiology are these specific areas, which we call the hidden areas. And that's the areas I really, in this projection, that I really want you guys to keep in mind. So the apical zones are areas where when you're trying to report things quickly or you're inexperienced, then it is an area where you'll miss small pneumothorax, for example, and also apical lung masses and pneumonia itself, okay? So always check the apices. So once you've done your whole system, you've done the airway, breathing, cardiac, your lung zones, and then soft tissue, bones, and medias, all the abdominal structures, then go back and look at these hidden areas, which is apices, the hilar, and as I explained to you, the hilar are very variable, but what you're really looking for is any calcified things, any masses, any big densities that suggest either an arterial issue or lymph nodes, because those are the commonest things that sit there. And what else is there? There's also pulmonary veins. Actually, once in my 3-year radiology career, I actually diagnosed a pulmonary artery dissection in a patient by the plain film and then correlating it with a CT. So it was crazy, and you could actually see it there. So yeah, so just looking at things that catch your eye in that area and then interpreting them further. And then the retrocardial space. So like this is an area behind the cardiac silhouette where the lingular lobe sits, and it's really hard at times. And the commonest thing that gets missed is retrocardiac mass and also lower lobe consolidation. Okay, so that's really important. And one of the ways you can detect that is something called a silhouette sign, where this border gets lost. Okay. Now you've got your 2 diaphragms and you're checking for free air under the diaphragm. This is not free air, obviously. It's a gastric bubble. We will look at some examples of that shortly. So these are hidden areas that your eyes should go back and check in case you've missed it after you've done your system. So as we said with Belinda, we were not really sure what was going on with her. So we sent her for a chest x-ray, and this is what we found. So who would like to have a go at interpreting this using the ABC and FD and everything else principles, an inside-out approach? Nobody?
Maybe we could all take a letter.
Yes. Okay, let's do that. I think that's a great idea, Chris. Thank you. Why don't we start off with Chris doing airway?
Yeah, I should have.
Sorry.
Okay, all right, I'll do airway. So okay, looking at the airway. So I'm coming down the trachea now. I can come down just above the carina, and then it's sort of whited out to me. It looks like it's maybe displaced to the right, being pulled across by whatever's happening in that right upper lobe. Am I supposed to? I can't remember. Does airway include lung, or it's just literally looking at the?
Just
okay.
Just the.
So yeah, and there looks to be that right-sided hilar. I can't tell if that's consolidation or whether there's something going on that right hilar area as well. And obviously I can't see right down to the right lung base. On the left side, maybe some increased lung markings there.
Yep, that's you're done with airway. That's excellent. Thank
okay,
you.
Cool.
Thanks, Chris. So airway. So next one is breathing. Who's going to be doing the lung field itself? Who'd like to have a go? Can I nominate Gordon?
Yes, you're more than welcome to come as your mentor.
Okay, so breathing it is. So breathing side of things wise, looking at the lung fields themselves and expansion of the lung, you can definitely see that there's a raised right hemidiaphragm there. So guys, whatever's happening on that side is sucking up the diaphragm. So all you can see is tracing the ribs out anteriorly. 1, 2, 3, 4, 5, and a bit ribs there. You can see that intersecting the middle point of the diaphragm on that right-hand side. In regards to the actual expansion of the lung on the left-hand side there, 1, 2, 3, 4, 5, 6, 7. 7 rib just comes into the actual diaphragm on the left-hand side there. You can see a gastric bubble underneath it, so confirming that that's the level of the diaphragm there above it. In regards to the actual expansion of the lungs, you can see that the actual lung markings all the way out to the peripheries of the lung fields on both sides, but the right-hand side, the right upper zone is definitely been whited out.
Yep, thank you, Gordon. That's excellent. So airway, breathing, circulation. Who'd like to have a go at the cardiac size and the borders of the heart itself? Dave, do you want to have a quick go?
Yeah, no worries. So as far as the cardiac size, it's difficult to ascertain because complete loss of that right cardiac border.
Yep.
Looking along the left, I believe I can just about make out the whole left cardiac border, and it looks reasonable, but again, very difficult to comment, just given the obscuring on the right-hand side.
Yep, excellent. That's great. That's all we can get out of that information. Now, next is diaphragm itself and the costophrenic angles. So, who wants to just let me know whether the costophrenic angles are blunted or whether there's something wrong with them or not? Georgia?
Yes, the costophrenic angles seem clear. And but the right hemidiaphragm seems elevated unless there's some consolidation there, but I think it looks like it's been lifted, the right hemidiaphragm.
Yep, no, you're correct. It is elevated. Excellent. And then the last thing is everything else. So I will choose out of everything else. There's still, we've got the soft tissue, the bones, and we're looking at our review areas and any tubes, pacemakers, etc. So I will be specific, and I'll ask in the everything else someone to just interpret the bones for me, please. Sorry, I can't see anyone, so these are the names I remembered, so I'm sorry about them. I think it was Anna. I remembered Anna.
Hi.
I'm Ruben. Can I?
Yes, yes, please. Yes, go ahead.
So the rib cage overall, I can't see too many problems with the rib cage. The ribs per se on the right and left look reasonably normal to me. So I can't see any abnormalities with the rib cage.
Okay, no worries. And aside from the rib cage, just if we don't worry about looking at the abnormality or not, tell me what other parts of the bones that we need to examine. So we've done the ribs, and what else?
The scapula.
Yep, have a look. Do you see anything on the scapula?
On the right, well, to be honest, I can't see any.
Is something going on with that AC joint on the right?
Yes, exactly. Just up here.
Yeah.
So that's the importance of looking at everything. But no, thank you. Sorry, what was your name? I missed that. So what was your name?
Ruben.
Ruben. Okay. Thank you, Ruben, for having a go. No, that's good. Okay, so I'll just quickly go through these findings. So what I really want everyone to get out of this talk is just to understand the basic anatomy and just an approach. So if you have an approach and you hang your hat on the systemic approach, which is A, B, C, D, and everything else, then you will go through a process. And if you practice a few times, which we have some cases towards the end here, then you will actually get your confidence in having a go. So if you follow that system, you will get most of the abnormalities with some practice. It's not that hard if you keep just using that system on repeat. It's just about repetition. So in here, yes, we've got some tracheal deviation, and that's as a consequence of this here, as you said rightly, Chris, that you couldn't follow through with the right right main bronchus. It's pacified, so there's something blocking it off, and that's causing the right upper lobe to get consolidated. Okay, and then that is collapsed and consolidated, and it's then pulling our middle and lower lobe up. That's called volume loss, and that's lifting up this diaphragm, which all of us together have found all those findings, which is excellent. In fact, this is just called the golden S sign because it's the right upper lobe because of the right hilar mass obstructing your right main bronchus. And in fact, this case was confirmed to be a non-small cell lung cancer, and it was just a big mass from a consolidation associated with a mass in the actual left lung. But in a chest x-ray, that's all we can find. So here, the horizontal fissure is pulled up, and so you've got upward shifting and then mediastinal shift as well, both because of volume loss. And then when we're looking at the soft tissues, we didn't really see anything. There was no free air under the diaphragm. There was just a normal gastric and the colon shadow here and gastric bubble, but there were some lytic lesions. So the lytic lesions was here. There's also one up here, it's more widened, and one up here, which Chris also identified. So I know this one is a little subtle, but over time, if you see here, we can follow the contours very nicely. And here you're seeing some irregularity. You're also seeing some irregularity here, which you don't appreciate on the other side. And this one is very pronounced, so that's a really good pick. Admittedly, if you this is sort of the lateral projection. I think the findings here were pretty challenging and subtle, but that's how it's projected. You can see normally you should see air up here, but there's sort of an increased density, which is confirming what we've seen on this side. So remember, lateral X-rays to confirm things and to check the vertebrae again, and that's what we normally try and do in this thing. So this was a report. The right upper zone is a pacified contagonist with a right hilar mass, loss of the right medial sternal contour, which I think Dave said to us because you couldn't see that in the cardiac silhouette. Then the horizontal fissure is retracted upwards, the hemidiaphragm mediastinal shift. There's a right clavicle and 10th rib lytic lesion, right lateral 5th rib subtle expansion suspicious lesion as well. Their conclusion, so you've got right hilar mass and lytic lesions in keeping with malignancy. And then you obviously need to do further imaging to work out exactly what's going on. So that comes to the next thing, which I'm sure you're all good at, is you break the bad news, unfortunately, to your patient, Belinda, and you ask her to bring a support person in. You refer to the local respiratory physician for assessment and biopsy, and we wish her all the best. She gets confirmed with small cell lung cancer, so she begins her treatment. Just a side note, very quickly, I'm not sure if anyone has heard of spikes as an approach to break bad news, but this is a great mnemonic and technique to use to help patients. And basically, if I'm just because of time, I'm just going to really rapidly run through it. And that's just, you choose a good setting, so private, comfortable area. You ask them to bring a support person. Perception, so you uncover what the family knows about the situation. You ask, so you invite them to ask any questions and what exactly they would want to know. Some patients, when they're hearing bad news, don't want to know everything. They just want to know the bare minimum, and others want to know every single nitty-gritty detail because that's how they process things better. And then knowledge, explain what's happening and use non-medical jargon, and then sort of give them some empathy with respects to their feelings and how they're responding, and that it's a lot, and recognizing that, and then summarize everything and what the next steps are for them. So that's a great tool to use when you're having these quite challenging conversations. So after you diagnose Belinda, you feel inspired to attend your local radiology meetings to learn how to interpret more chest x-rays. So now we're going to have a go with some cases. But yeah. So our presentation here is lower chest and epigastric pain in a 65-year-old male. This is the chest x-ray. I'm happy for everyone to either have a go and feel they don't need to stress out, but if you want me to start it off, like what would everyone prefer? Do you want to do airway, breathing, circulation in this one, and then we'll decide how to get there? Okay, someone have a go at the airway first.
The way it's largely central.
Yep.
Yeah.
Yep, thought to be normal. Excellent. Breathing.
Breathing, the air spaces are fairly reasonably well aerated. I can't see any effusion or anything. The corners and the lung seems to be well aerated. I can't see any pneumothorax or anything.
Excellent. Yep, thought to be normal. So airway, breathing is done. Circulation, which is cardiac.
Cardiac. The left ventricular border seems to be a little bit prominent, but
what do you mean by the left ventricular border? Do you mean this, or do you mean this side? This.
Whether there is a bit of an element of left ventricular hypertrophy.
Okay. Yep. I see what you're saying. Yep, that's a good pick. Yes.
And the bones
Airway,
essentially
breathing,
look
circulation. No, the next is D. D is for diaphragm. So what?
diaphragm.
Yep.
So the right diaphragm seems to be higher than the left.
Thought to be normal, but what else is? Can you look at the
there's
diaphragm?
a lot of air under the left diaphragm,
Yes.
and I'm not sure whether it leads to with epigastric vein or perforated gastric.
Yes. Yes. Great. You've picked the abnormality. That's excellent. So so diaphragm is done. What's the next one? Airway, breathing, cardiac, diaphragm, and then everything else, which is just finish your system, which is the bones and soft tissue.
The bones. Essentially, the bones, you can't find any lytic lesions or anything. The rib cage looks normal. Clavicle on both sides looks normal. Scapula looks normal as well.
Excellent. So perfect. So airway was fine. The lung fields were fine. Yes, thought to be normal. These hilar, one could argue they look a little prominent, but I would say they just look a bit calcified. So that's thought to be normal. Then cardiac's a little bit, you're right. There is an element probably of left ventricular hypertrophy. It does look more pronounced because it should be 1 to 1/3 ratio. We won't worry about that just now. And then basically, if we go to the diaphragm, we're following the diaphragm. See here, we can see a slither under the diaphragm of free air. We can see some free air here. And that's our sort of gastric bubbles a little bit down here. So something has perforated, and that's why the patient is presenting with lower chest pain and epigastric pain, because it's a perforated viscus. So that's the answer to that one. And basically we just need to so free air under both diaphragms. So it's an urgent surgical referral, and the patient's probably going to be pretty unstable if we don't do something about it. Good job. That's great, Ruben. Thank you.
Thanks.
So the next presentation is a male presents at local emergency department with sudden onset left-sided pleuritic chest pain, 20 years of age. So we're using airway, breathing, cardiac, diaphragm, everything else as our approach to interpret. We're assuming the image quality is good in all of these, so we're not worrying about that. But yeah, who wants to have a go? Maybe Dave, do you want to start off with just the airway, breathing, or whatever you feel comfortable doing?
Yeah, sure. So from what I can see, the trachea appears to be in the midline. And I always have a bit of trouble kind of looking further down the airways, in truth.
No, that's fine. So I'm happy to help you out with that. Yeah. So see if you're looking at, so this will be your T1. So basically what you do is you follow there and you just come down and you can see that. I know the projection is just a little, it's hard, isn't it? But if you had a chest x-ray in front of you and you put light behind it, you will see this. So there and there. So yes, your airway is thought to be normal. Yep. And the next one is breathing. Do you want to have a look through that for me?
Yeah. So like it can be tricky without like a comparison, but I think maybe some extra lung markings in the right lower zone.
Yeah.
And maybe some increased perihilar markings again, depending on what this person's chest X-ray normally looks like.
Yeah. No, that's fair. Yeah. So that's fine. There was nothing really else that I needed to get out of that. So breathing is done. The next is the cardiac silhouette and the mediastinum. When you're doing the cardiac, so you're not just actually only looking at the heart, you're looking at all the mediastinal shadows. Okay, so you're looking at the aortic knuckle, pulmonary trunk, the heart, then the cardiophrenic angles and everything, okay? And then you're also going to compare to the lateral. So I want you to follow that through slowly and have a go.
Yep, sure. So I think the aortic knuckle looks good.
Yes, it's
and
not. So the way instead of saying looks good, it's just
Yep.
it's not widened. No, you're
Not
doing
widened.
great. Yep.
Yeah.
Good. Yeah.
And then I'm noticing some kind of obscurings of the left cardiac border. The first one kind of just as it, I don't know, kind of at the having trouble kind of locating it, but yeah,
Yeah.
kind of just there. That's the first
Okay.
one there.
Yeah.
Kind of a circular shadow there that's obscuring the left heart border, and then there's another one kind of just down above the diaphragm, like where
Yes.
looks like we can see the border, but then extra shadow to the left of it.
Yep. Good pick. Yep. Keep going.
And I would say looking down the right border, potentially also a little bit of obscuring there, like just kind of at the same level as the kind of superior obscuring on the left. But otherwise, I've got a good right heart border down to the diaphragm. And then the lateral view, in truth, I just can't really see the front of the heart properly. Like I can't make out contours there at all, which makes me think it's abnormal, but I don't know how to comment further than that.
Yep, no, that's fine. And then if you're to follow the diaphragm with D.
So I can see both costophrenic angles well.
Yeah.
Oh, sorry, costodiaphragmatic angles well. But it appears that the left diaphragm is lower than the right.
Yep. Yep. Left is lower than the right. No, similar. Yep. Okay. Well, no, that's really good. And then everything else. Do you want to just quickly check the bones for us?
Yep. Looking through the ribs, I can't see any obvious abnormalities.
Excellent. So this approach again highlights that you've actually picked up most of the stuff without really knowing what it is, but that's okay. So this here is the reason why you can see extra shadowing and extra stuff is because there's actually free air in the mediastinum and it's following the entire cardiac border here. So there's free air, there's interstitial lung markings that are increased in this person because they've got pulmonary interstitial emphysema, which is besides the point. So basically this kid came in with pneuma mediastinum, which is so free air in the mediastinum following the cardiac border and also tracking all the way down the diaphragm. So here you can see it a bit better on the lateral. Do you see that? And then all these shadows up here, which is you thought looked abnormal, and all here because there's just free air around the mediastinum following all the way through. And the interstitial lung markings are increased because they had severe asthma, and from the asthmatic attack, they got pneumo mediastinum. So that was this chest X-ray. It was a very subtle finding, but it was. I just wanted you to understand that if you use this system, even though you don't know exactly what's going on, you can actually pretty much highlight the parts that are abnormal, and then with practice, you can put it together to actually understand the diagnosis. Does anyone have any questions on this one?
I definitely wouldn't have got that, Komal. So well done, Dave.
he literally, because you know how, Dave, you said that you see this little fat thing here, and this thing here, they're both epicardial fat, and it's differentiated, and you wouldn't notice it at any other time. The only reason you notice it is we started to get this shadow here, and that's the free air and then mediastinum. So that's why your eye went to these things, because it was something in between it. Otherwise, it would just be one giant blob. Does that make sense?
Yeah, it does.
Yeah.
I'm going to be looking for exactly these findings in the next 100 X-rays I look at.
No, but it's so cool. Like it's what I love about chest X-rays, and just that subtle difference in density has then differentiated this. Otherwise, this would just be one whole blob, and this would just be your pulmonary trunk. That would be your aortic knuckle, and you wouldn't know, your eye wouldn't go there. It's only gone there because there's this shadowing. Yeah, so that's excellent. Good job. Well done, guys, for having a go. That's excellent. So the next part is swallowing discomfort in a child that's a male and sudden onset. Who wants to have a go?
We might have to just notice the time, Colin. It's 8:30, so I don't know
okay.
if
No
might
problems.
have to wrap it up.
Yeah. Okay. No issues. So this one really quickly is a fishbone injury in a child. You can see the fishbone sitting there, and it's caused essentially basically pneumomediastinum as well, but it's higher up because of the perforation in the airway and the esophagus, which is causing surgical emphysema. And then this one was chest pain in a young male, and it's a giant pneumothorax, and this is his lung here. So if you follow the ABCD system, you'll be fine. This is also a right-sided pneumothorax. What I wanted to get out of this one here was what you need to know. When you go, you can review this on your own time. Here, in this one, this is a spontaneous pneumothorax. And there's no tracheal deviation, so it's not under tension or mediastinal shift. But when you see here, the trachea is moved, the heart's moved, that's called a pneumothorax in under tension because of the mediastinal shift. And because that's compressing all the major vessels, that's a medical emergency and the patient can die really quickly. But the presentation in both those are the same. However, this person would start to get hemodynamically unstable quite rapidly, and they need a chest drain to save their life ASAP. And then this one is, what is this one? This one is subjective fevers, lightheadedness. I think this is a tension pneumothorax we've just done. I'm just trying to remember what I did with this one, sorry.
Something to do with the trachea there, off to the right.
Yeah, it's deviated. I think it was a retrosternal goiter. That's retrosternal mass is here. Yep. Okay, and then this is, who can spot diagnose this one for me? 85-year-old male, acute chest pain. Yes, exactly. And if you follow the ABC system, you will understand that this mediastinal contour is abnormal, and that's the end of that.
Cool.
Good job. Thanks, guys, for having a go.
Thanks,
and hopefully you'll have a lovely day. How do I get back to this team? Hi. All right.
Again. That was fantastic. Thank you so much. Before we wrap up, any questions? No questions. It was quite group today, hey? Trying to pull. Thank you so much for that. That was incredible. So much information. Yeah, I was never going to have a go because they all look the same to me, obviously. I wish I could have helped.
You could use A, B, C, D, and E next time. Sydney, have a crack, okay?
Now, a couple of things. I have popped the link to the Slido in the chat, so if you can fill in the evaluation for today so we can pass on the feedback to Dr. Saini, that would be fantastic. Also, next Monday night at Wombrel Surf Club or Breakers, we have a regional workforce planning consultation. So we're trying to get as many coasties along to this to provide feedback on the current workforce on the coast. We know it's a huge topic, and we're trying at the PHN to do our best to fill the gaps. So if you can come along and provide any feedback, as well as there'll be dinner as well, that would be fantastic. We're trying to get our numbers up because we can't do anything if we don't get the feedback. So that would be fantastically appreciated. Besides that, we are back on the 15th with Dr. Bajia and Georgia topic for that one.
So it's oncology, and I think the topic is to be confirmed, but hopefully it's something asking all our questions of how we should be managing all the little complications of our oncology patients undergoing treatment.
Perfect. Well, if there are no questions, we'll wrap up for today and we'll see you in a fortnight.
Thanks. Bye. See ya.
Thanks, everybody.
Bye. See ya.
Thank you very much.
Bye-bye.